And kind introduction, and thank you to the team here for inviting me to come here and speak. I'm very excited to be here. And I apologize to Susan for the very long title. We're going to erase that and call our talk today MEGMO. I have no disclosures other than I will try my hardest to keep you awake after lunch. I know everyone's bellies are full and it's easy to want to sit back and relax. So I have some videos and some pictures that hopefully will make this an exciting and engaging talk today. Our goals of our project were first to perform a high-fidelity ECPR simulation in a multidisciplinary setting. We have had some different ECPR simulations that we have run. They have been primarily with our perfusion team or with our ECMO team, but nothing that we had done comprehensively with our entire multidisciplinary team. Secondly, to evaluate the change in surveys, we wanted to survey our staff to ask them what their comfort level was, as well as their readiness prior to and after doing the simulation scenarios. Thirdly, we wanted to effectively video debrief with our MCS specialist that was doing the priming as well as the initiation for the ECMO activation. And lastly, and ultimately, our hospital-wide goal was to improve our ECLS initiation time to less than 30 minutes. So a little background on our team at Nationwide Children's Hospital. We have 4 CT surgeons. We have 6 perfusionists. We have 9 dedicated OR nurses that come to the bedside for all of our cardiac initiations. We have 8 what we call MCS specialists that are available 24/7 in the ICU, and I'll talk in a subsequent slide a little bit about how we've actually set up our team and sort of frayed from what we have done historically from a staffing standpoint for our ECMO team. We then have 14 RNs that have been trained at the bedside to manage an ECMO patient, so we call them RN bedside specialists. We have 10 CTICU physicians and 12 CTICU APNs, so you can imagine that this is essentially how our ICU looks, especially when trying to turn the ship and change a process or implement some new fashion to be able to decrease these initiation times. So we utilize at our institution key driver diagrams. We have a pretty robust quality improvement team at our hospital, and we have one assigned to each one of our service lines that will help us with the tools and methodologies behind some quality improvement studies. So for this study, we started with a key driver diagram to help us really understand the roadmap and how to successfully decrease these times. So our specific aim, or our global aim for this project, was to increase the number of cases in which ECMO circuits are ready within 30 minutes of ECMO activation for heart center patients from 31% at baseline to 100% by June 30th of 2018. We then had some sub-aims that we also wanted to focus on, and the first was to decrease the median time for the circuit preparation. And at baseline, we were around 45 minutes. It was taking our team of specialists to prime and have a circuit ready for initiation. Our secondary is to increase the percent of simulation in which our staff members can prepare an ECMO circuit within 30 minutes. So again, we wanted to decrease this time clinically as well as to be able to do that in the simulation environment as well. A little history on our program is in October of 2015, we had some administrative involvement and decision that we were going to actually split our team. So we historically had what we would consider a dedicated ECMO team, where we had about 20 specialists, 20 to 22 specialists that were comprised of RNs as well as RTs that we trained to prime, initiate, troubleshoot, as well as sit at the bedside with our patients. We sort of encountered a challenge as an institution when we had 5 ECMOs up, which was considered a stressor to our system at our institution, because we have 3 different units that we run ECMO in. So 5 different patients in different units when we traditionally staff 2 people to run ECMO during the day. So this is when we started trying to think of some way to creatively figure out a model that might work better so that we could effectively staff as many ECMOs as needed at any given time at our hospital. And this ended up reaching administration because we were diverting patients from our institution that were high risk for ECMO because we were unable to staff them. So these discussions began in October of 2015. In February of 2016 is when we actually started training for the split. So we had used what we had historically had, which was our ECMO specialist. We called this new team MCS, for Mechanical Circulatory Support Specialists. And they essentially function as an ECMO specialist, but they're also trained on VADs and troubleshooting VADs as well as rounding on these patients. The major difference is that they are not actually sitting at the bedside with these patients. We additionally trained nurses that will sit at the bedside and manage these patients from hour to hour as an ECMO specialist historically would have. Our MCS specialist then is available for all patients and any troubleshooting, any codes, any activations. So they're sort of the second set of hands on the unit, as well as the higher level set of skills that would be available 24/7. We do have our perfusion team that is on call as well 24/7, but we do have a 30-minute response time. And what we found is that in 2016, 100% of our activations in our CTICU were all ECPR. So we found that there's really this changing climate and acuity at our institution where we really needed a higher set of skilled individuals that are on the unit and available 24/7. So that was in February of 2016. In April of 2016 is when we sent an entire cohort of nurses through the training program, and they were considered RN bedside specialists. They were then trained on priming, initiating, changing out oxygenators, and whatnot. The model, though, is not for them to be doing that alone, but they would call for the MCS specialist to be at the bedside to help them, and then perfusion would also be on their way. In March of 2017 is when we started simulation training with our entire CTICU. And in the third quarter is when we did what I'm going to present to you today, which is what we called the ECMO Megacode simulation. And this is where we utilize the Google Glass to help with recording the first-person video for the MCS person. In September of 2018, we trained an additional cohort of nurses to come through the training program to, again, be these bedside specialists. We do have a very young nursing staff in our ICU, and we've recently, in the last 2 years, had a lot of turnover. So some of this is truly trying to staff and have trained and available specialists so that when that turnover or when some of these higher level nurses go to APN school or decide for different career paths, that we do have that sort of back-staffed and trained and ready to fill those holes. So our CTICU has a nursing skills day. These occur quarterly. And in 2017 is when we first dedicated this ECMO skills day. So our entire, I believe we have 220 nurses in the CTICU, all went through a Megacode involving ECMO activation through initiation. Again, our primary focus of this was for it to be multidisciplinary. So you'll see that we have sort of all the common players. So the RNs, the RTs, APNs, our CTICU attendings. And again, while those are our core components, it still takes a lot to actually get these people to come in on their day off and to kind of take time out of that to buy into the value of this process. So I'm very appreciative to our team for really understanding how important this is for our patients. But in addition, the part that was really exciting for me is that we had a lot of buy-in outside of our ICU. So our dispatching center was helpful in sending out pages that were real, but obviously said mock code in them, as well as our blood bank. So they actually helped us go through the entire process of what it takes from someone coming down to get the blood out of the blood bank. And they actually practiced these scenarios with us as well. And we ended up finding a lot of bottleneck processes that were occurring in our blood bank, so they were very open to working with us during this skills day. So our agenda for the day is that we started with a pre-survey, so we surveyed all of the team that came in for the day and asked them some very specific questions that we'll talk about in the next slide, but essentially trying to assess their comfort and knowledge with ECMO. We then did a 1-hour lecture on ECMO activation. And the thing that we find that it becomes challenging and is a very easy thing to train through is actually getting the room ready and getting the patient ready for cannulation. And at times we have our entire cardiac team that arrives and we don't have the patient in the right position or an x-ray plate below them or the room isn't in the right orientation. So those were things that we really wanted to focus on this first set of training was sort of that low-hanging fruit. We then completed the mock ECPR scenario, and again, this involved, we call it H4A, but it's essentially our cardiac step-down unit, and our H4B, which is our CTICU. So it involved both units and our entire comprehensive nursing staff. We then lastly surveyed the staff at the end of that scenario after we did the debrief. This is an image of the pre-survey that we administered. Two things I primarily want to point out are the two questions asking if they had previous experience in an ECMO activation, yes or no, and then secondly, whether you're comfortable with the ECMO activation process. The agenda and the patient that we presented, I'll read this. I realize that the text is a little bit small, so I'll read through this, but this is the scenario that we presented to the team. Johnny Smith is a 1-month-old infant who was initially admitted at 15 days of life with respiratory distress. At that time, he was found to have cardiomyopathy. After stabilization with milrinone infusion in the CTICU, the patient was successfully transitioned to enteral heart failure regimen. He was discharged home at 25 days of age. Over the preceding 36 hours, he has progressive loss of appetite, increase in spitting up, and over the past 8 hours, he's taking decreased PO with small emesis with every feed. And he has been somewhat fussy, but otherwise acting normal. His meds, the medications that he is on currently are carvedilol, enalapril, spironolactone, Lasix, and aspirin. No drug allergies. So we present this to the entire team, and then we begin with what we call a practitioner sign out. So a practitioner is handing off to our step-down unit and giving the history of the patient. So the patient was admitted to our step-down unit yesterday. Clinically, he was warm and well perfused. He was mildly tachypnic with normal work of breathing. And overnight and into this morning, he has been more fussy with a modest increase in his respiratory rate. He is not interested in taking PO at all, so IV fluids have been started 6 hours ago. We then start the simulation scenario. Again, we have a Laridol and the dolls that are utilized in simulation, so those were part of this, as well as all the simulation monitors are in our actual clinical setting, so we did close down 2 rooms for the day. We expect, this is sort of the summary on the board for the simulation operator. So on H4A, so our step-down unit, the patient experiences ectopy, VTAC, and then VFib arrest. The patient then requires intubation. We then get return of spontaneous circulation, and the team decides to transfer the patient to our cardiac intensive care unit. That's our typical process flow for a patient that decompensates. So that occurs. We then rolled the patient down the hallway into our ICU. The handoff occurs in our ICU, and then, surprise, surprise, the patient has VTAC, VFib, arrest. We then run a mock code scenario with our ICU team, including CPR, as well as all the meds. We then activated ECMO, went all the way to having the surgical team arrive, cannulating the patient, initiating, and up to full flows with that patient, and then it was considered, the simulation was complete. Here's some images of the room. Again, this is one of our cardiac ICU isolation rooms. You can see that there's an immense amount of people in here, and unfortunately, this is also sometimes what we see in a clinical scenario is people hear code and all these people kind of start gathering and are not necessarily functioning in a role that's necessary, which is part of what our training was, to make sure that we have one person that's in charge of making sure that the people that are there are necessary and that they're actually helping with the patient and not just people in the way. So this was part of that drill process as well. The red circles you'll see there are the evaluators. So we had evaluators placed throughout the room that were watching different roles. One of the roles, the photo on the left, is actually the person that is specifically watching and scoring the MCS person. So their priming process, their efficiency, accuracy, and all the way through initiation. So that person was primarily focused on that. The other person on the photo on the right is looking at the room movement and evaluating the bedside nurse in her role. And that way we were able to give direct feedback. When we looked at the post-survey questions, these are the results from pre to post. The 2 questions that I primarily want to focus on are at the bottom there. And the first one is their comfort with ECMO activation. And you'll see in the yellow highlighted in the red arrow there that pre-survey, 34% of our nursing staff said that they disagreed that they were comfortable with ECMO activation. After we did the ECMO simulation, that decreased to 1%. And then when you look at the positive side of that response, 25% said that they were comfortable with activation. And after doing the simulation, that increased to 52%. When we asked them if they felt that their role was well defined, that is one piece of feedback that we have gotten from activations and debriefings clinically, is that some of the ancillary or specifically like an RT they don't know where to go. They're trying to bag a patient, so do I go under the drapes? Do I go to the right side? Do I go to the left side of the bed? And what exactly is my role? We have multiple bedside nurses that will come in to assist with a code, and actually understanding what their role is so important to the efficiency for these patients. So that is one thing we really wanted to focus on specifically with ECMO, is if people really felt that they understood their role. So prior to doing the simulation, 22% said that they disagreed, that they understood their role, and that decreased to 3% after doing the simulation. And then 35% said that they did strongly agree that they understood their role, and after doing the simulation, 68% said that they agreed with that statement. And you'll see that both of those are statistically significant. So we were very excited to see that this appears to be beneficial to our staff as far as their comfort level with ECMO. On the bottom, there are 4 additional questions that we asked just after the survey, and asking them whether they felt that the training better prepared them to manage a similar situation. Secondly, if it developed a better understanding of medications and how they should be administered. Expanding their clinical knowledge as well as critical thinking, which is something we have been working with our team a lot, is truly how to simulate critical thinking skills and training and education through that. And then lastly, whether or not that they felt that the debriefing helped provide insights as well as collaboration amongst our teams. And you'll see that 85 to 87% of all of those said that they strongly agreed. So now we wanted to primarily focus, obviously, as a perfusionist and managing our team of ECMO specialists, looking specifically at our specialists and whether or not there's a way for us to improve their efficiency or the accuracy in what they're doing through simulation. So that's where we focused primarily. All of our interventions for this project was looking specifically at our team. We also changed our title of our project, and thinking originally that it would be ECMO activation to on time. However, when we're really trying to focus on a team and figure out what the actual issues or challenges are, we wanted to look at exactly our team. So what can we control? We can't control if a surgeon shows up late, or if there's difficulty cannulation, or if the room isn't ready. So to sort of separate those things from the actual clinical side of an ECMO specialist, we wanted to see how long does it take from the time we activate until our circuit is ready, because those are the things that we felt we had control over with our team as far as training and education and simulation. So we did change our global goal to that. So looking specifically at our interventions, the first one on the top there is streamline the MCS specialist circuit preparation checklist to mission critical tasks. And I think as a profession and us sort of newly entering into this quality world and adding things to checklists because we understand their value and their safety, in our institution, we were way overkilling the checklist. So we had so many things on there that it was truly causing a delay. And when we sat down and looked at it, we said, well, how many of things are really critical to get on ECMO? So we actually ended up separating them to a checklist to get on, and then once you're on, secondarily a checklist for things that are less critical to patient management. Secondly, the blood products that we use to prime the circuit. So we worked on streamlining this. Our institutional practice is to have everything irradiated. So we went back and looked through some of our data. The risk or the concern a lot is patients with DiGeorge syndrome that might be exposed to products that are not irradiated. So we went back and looked at our data, and our actual number of patients that were positive were incredibly low, as well as the other challenge is a lot of our patients are neonates that are newborns, and we don't have the PKU results back. So we were just irradiating everything. And irradiation at our institution, utilizing our machine, takes 17 minutes. So that's a huge time delay when we're trying to get our times to below 30 minutes. So we implemented a process where our APNs can differentiate whether or not this patient is at risk and should have irradiated blood, or if this is a patient where we really should just go ahead if they're arresting or it's emergent and we need to get on more quickly. We also changed the workflow for our CTICU APNs. So our APNs are the ones that activate ECMO as well as communicate with all the outside resources like blood bank and surgery to get everyone who's necessary to the bedside. And what we found is that the process was completely broken. They were making phone calls and people were calling back, and then we had other people at the bedside that were then additionally calling down to the blood bank. So the blood bank is getting inundated with 6 phone calls on one activation and then getting different messages. So we streamlined that to only one person is communicating with blood bank or any outside resources. And we also streamlined, we basically made a key card that's on the charge nurse's notepad, and it says exactly what they call the blood bank, they say I'm activating ECMO and this bed space, this weight, I need this blood. So it's very directed exactly what they're going to communicate, and there's no confusion that might occur during that process. We also worked with our MCS specialist to delegate some tasks. Again, this person is in-house 24/7, and we do have a bedside nurse that's trained with this, but in the actual activation role, sometimes the nurse is not actually there to start assisting immediately. And the perfusionist is at home just waking up to a pager trying to get scrubs on. So we worked with them to actually delegate because, again, we do have a multitude of nurses that are available as resources or as floats that come to a code. So we started delegating some of the drawing up of medications as well as drawing up some of the blood products that we put in the circuit so that the MCS specialist can focus truly on getting transducer zeroed and circuit debubbled, and then all the other ancillary stuff is ready immediately to add to the prime. We then, we worked on talked through whether or not we wanted to have a wet primed circuit. Historically, we've only had dry circuits available, so in this discussion, we decided that it was worth it to go ahead and have wet circuits available at all times. So as soon as blood is available, our circuit and crystalloid would be warmed, and we're able to chase that out and immediately be ready for activation. In those discussions, we also completed a study where we looked at any bacterial or fungal growth in ECMO circuits, and we actually tested those out to 90 days. We did 8 different circuits, and there was no growth in any of the circuits. We're working on actually getting that work published currently. But in sake of safety and going from 30 to 90 days, we thought that we would probably be safer to start at 60. So we did change our institutional protocol where we will keep a wet primed ECMO circuit available for 60 days. We also, in the effort to start this new role, this new model, shifted a lot of our attention to education for our bedside nurses because our MCS specialists who had already been on our team for lots of years and had lots of experience and had already been through our ECMO class. So the focus really shifted to our bedside nurses and making sure that they were safe and comfortable and that we had trained them well. And in that, we found that we were actually lacking on some of the skills and simulations and checkoffs on our MCS team. So during this process, we went back and made sure that we were having monthly checkoffs for our MCS team as well. And then lastly, what you'll see here is the reinforcing the staff training through the simulations of code all the way through ECMO. So as opposed to just doing oxygenator changeout, limb changeouts, emergency drills, we really started making sure that we were doing monthly simulation through the activation process. We utilized Google Glass for the MCS specialists during these megacodes, and this is how we were able to record their actions and that process through the megacode. It's very difficult to capture what the specialist is doing exactly, even having somebody follow them through. As you all know, there's 1,000 things happening at once, and you're grabbing for one thing and dropping fluid over here and grabbing a clamp, and it was really important for us to make sure that we would be able to replay these things and talk through exactly how we really wanted to standardize how our team was functioning and handling different scenarios as well as their priming. So this was really important to us to have this recording of this process. Again, it was helpful in debriefing as well. We debriefed with each MCS specialist after every Megacode. So we would sit down and re-watch through the video with them and pause it and talk through why they did what they did, or maybe if there was an improvement or something that we could utilize for the rest of our team that they did really well. This also helps us identify variability. So if we're trying to train U prime in this sequence, but then we're not really sure that everybody does that and perfusionists aren't necessarily there to see it, this was also our way to make sure that we were trying to standardize our process for priming with our team. Again, allows us to see their strengths and sort of build upon what they're doing really well and apply that to the rest of the team, as well as ways that we can have some time-saving measures or implementation. And this video is actually one of our ICU docs who works with us on the simulation program created this, and it is from the Google Glass, watching the MCS specialists as they're priming throughout it. And there's a little bit of dramatics and some theatrical stuff going on, so it's pretty funny. Put a lot of time in that if you can't. So in all seriousness, it was very well received. Our team was open to wearing the glasses and really being vulnerable during that process. Again, there was a little bit of initial hesitation of like, well, hang on just a second. So you're going to watch everything I do and criticize it all. So it was great. We really tried to make it a learning experience for all of us, and it truly was. So I'm very appreciative to our team being open to that. The debriefing was monumental to making these changes with our team and to being able to look through these together. And even people who are open to being willing to share it with the rest of the team, we've used this during staff meetings to talk through different ways of kind of handling things. So it's been really incredible for us to learn through this technology. We are now implementing this in our CTICU simulation codes that don't necessarily involve ECMO, but we are having attendings, fellows, bedside nurses wear these so that then we can get different perspectives throughout codes and try to implement these changes universally amongst different roles in our ICU. One quote that someone wrote when we asked them for some team feedback that I thought was really significant was from one of our nurses, and she said, recently I participated in an ECMO simulation where my role was the charge nurse. I'm a newer charge nurse on the unit and have not been in charge during an ECMO activation. Within 2 weeks after doing ECMO simulation, I was in the role of charge nurse when a patient arrested onto ECMO. To say that the simulation helped prepare me as a charge nurse for the ECMO activation would be an understatement. So that was really good to see that they really saw the value in that. This is a control chart looking at these actual activation times. So our desired direction is down to decrease that time. On the x-axis, you'll see is the date, and these are date by activations. On the y-axis are the minutes, and this chart is looking at ECMO activation all the way through on, so just not just circuit ready. You'll see in October 2015 is when our team split, and you can see that the data is really varied during that period of time. In February of 2016 is when we trained our team, and you can see that there's sort of a downward trend for the activation time. In March of 2017 is when we began the simulation in the CTICU as well as the Megacode that I just showed you. And then September of 2018 is when we began our second cohort of nurses. And you'll see that our baseline was around 83 minutes, I believe was our baseline number. And you'll see that there was actually a shift in our baseline and decreased to about 42 minutes. So a pretty significant change from an institution just with the utilization of simulation and truly getting everybody on board for these practice sessions. When we looked at our activation to ready time, again, this is just the circuit ready portion, we were running somewhere around 45 minutes to get a circuit ready, and you'll see that in around 2016 is when that really decreased to about 30 minutes, and then the last part of 2018, you'll see that sort of one specific dot there, if that weren't there, according to QI rules, we would actually be able to shift our baseline again and have a further decrease, which is somewhere below or close to about 20 minutes. But we decided to keep that one in. It was sort of an outlier. We had some issues with communication with the blood bank, and they were unable to get blood products to the bedside, and the patient was like 2.6 kilos and was already getting boluses of crystalloids, so we felt that it was vital for this patient to wait for the blood products in the ECMO circuit. But we truly kept that in there because that's real life, and these are sort of the situations that we face, and when we find them as challenges and ways that we can sort of push past them as a team. So we decided to keep that outlier in the data, and since then, I'm excited to say that we just had an activation last week, and our activation time was below 20 minutes, so that actually shifts our baseline down to about 23 minutes. So we're really excited about the progress that this has made for our institution and ultimately for our patients to get them on support faster. Looking at future directions, again, there are multiple events that are occurring all at the same time. So whether we look specifically at the time from activation to get blood at the bedside, whether we look at time to get surgery to the bedside, to get the room ready, there's so many components that we can really look at data and then drive down into those processes. So those are things that we're looking at now is a little bit further and below the surface on what's actually occurring as an institution and as a system, and things that we can improve on. And a huge thank you to my team. All of our Perfusion team was very active and participated and filled roles when we needed them to. So a huge thank you to my team as well as our institution for their buy-in on this process. And thank you for your time.
Thank you, Ashley. Great job on this.
Thank you.
And as you're the quality and safety officer of your department as well, so I appreciate what you're doing with it and your goals that you're trying to achieve. And you had mentioned that 25 to get comfortable at the very beginning, and then they increased it to 52%. 52% still doesn't seem like it's really positive there. Mm-hmm. So how many times, do you think that you should go through these simulations, and are you comfortable with the 52%, or should it, I would think you'd want to, above 90% at least. So just wanted to see how many times you had to go through the simulation and what you would do for improvement.
Great, thank you. Yes, absolutely. We are not okay with 52% at all, and look forward to continuing these. And I think that's actually a really great point, and something that maybe we do need to monitor is how many simulation sessions that they have participated in, and see if there's a correlation between that change, and maybe see if there's a number that is required, whether it be over a certain period of time, to see what really makes someone feel comfortable over time, and not just a bunch of training and you feel really good and then you don't do a simulation for 2 months and then you have 6 activations. So that's absolutely something that we can look at and see if there is a way to see how many sessions they need to go through. We were excited primarily that it doubled with one session, so again, concurrent ones and the amount of resources, it definitely seems to be a return on that investment. So yeah, absolutely, that's a good question. Thank you.
Question here about your circuits and how often they're checked for bacterial growth. Is that something that you do routinely? I know you did a study, on it. But.
Yeah, great question. We do not routinely do that. We did look at, we do continue to monitor patient infections if that has changed since we have changed our practice. But we do not routinely run bacterial or fungal growth in our clinical circuits. That was just a study that was completed.
Somebody's asking how many circuits that you've put in, after 30 days. I mean, do you usually use them before 30 days, or are you using them in that 30 to 60 day window?
We typically use them within 30 days. We have had 2 that have gone past 30 days. I'm not going to accurately give you numbers. They were so close to 30. They were under 40, so sometime between 30 and 40 days. And those were the 2 patients that we have been following to watch for infections. But yeah, generally we're close to 30. Yep. Any other questions? Good. Okay, thank you. Thank you so much. Thank you.
Thank you, Ashley.